Okay, good evening, everybody, and welcome to this evening's webinar, A GP's Guide to Thrombosis and Thrombocytopenia Syndrome. We are joined by our presenters this evening, Associate Professor Vivien Chen, Dr. Danny Hsu, and our facilitators, Associate Professor Charlotte Hespe and Dr. Ai-Vee Chua. Before we go any further, I would like to make an acknowledgement of country. I would like to acknowledge the traditional owners of the lands from where each of us is joining this webinar today, and I wish to pay my respects to their elders past, present, and emerging. Just some housekeeping really quickly so you know how to interact with us and your control panel this evening. You should all have a control panel that appears as a thin black bar at the bottom of your screen. If you can't see this, just take your cursor, hover it over the bottom of the shared presentation screen, and it will appear. Everybody has been placed on listen only mode with so many people online. We don't want learning to be disrupted by any background noise. So please talk to us using your question and answers box. We will do our best to respond to questions online. We've got a huge number of people joining us tonight in only a very short time. So realistically, we won't be able to get to all of them, but we will try and get to the most pressing ones that are coming through. While you have a look there at what we're going to try and cover this evening, I'm just going to formally introduce our presenters. Associate Professor Vivien Chen is the Thrombosis Hemostasis Lead Staff Specialist Haematologist at Concord Hospital, Sydney. She is Head of Basic and Translational Research in Concord Haematology with focus on bench to bedside research in clotting and bleeding disorders. Associate Professor Chen heads the Platelet and Thrombosis Research Laboratory at the Anzac Research Institute. Vivien is also the chair of the THANS, which is the Thrombosis and Haemostasis Society of Australia and New Zealand VIT Advisory Group. Dr. Danny Hsu is a clinical and laboratory haematologist based at Liverpool Hospital. He is the Director of Therapeutic Apheresis and Clinical Lead of Immune Haematology. His main clinical and research interests are in the field of immune thrombocytopenias, thrombotic microangiopathies, and complement-mediated disorders. Danny is the chair of the THANS subcommittee on VIT communications, which developed the THANS multidisciplinary VIT guidelines for doctors. Associate Professor Charlotte Hespe works part-time in clinical general practice in inner city Glebe as a principal of a 16-doctor group practice. She also works as head of general practice and primary care research for the University of Notre Dame, Australia, School of Medicine, Sydney. She is actively involved with the RACGP and is the current chair of RACGP, NSW and ACT Faculty Council and a director on the RACGP board, my apologies. Dr. Ai-Vee Chua is a GP principal at Dubbo Family Doctors in Western New South Wales. Her practice has been a COVID-19 vaccination site since week 1 of the vaccine rollout in general practice. She is one of the clinical leads with New South Wales Health's COVID-19 primary care community of practice. Ai-Vee contributed to the development of the VIT guidelines for doctors as the RACGP representative on the VIT multidisciplinary group led by THANS. So thank you to Vivien, Danny, Charlotte, and Ai-Vee for joining us this evening. Without anything further from me, we're going to head over to Danny now, who is going to get us started for this evening. So thank you and welcome, Danny.
Thank you very much for having me, and thank you, to the audience that's joining us. I've gathered that we have many people this evening really dialing into the webinar. So really today I'm going to talk about thrombosis thrombocytopenia syndrome, which I'm sure many of you sort of have encountered over the last few months. So let's, in a way, take a step back. I mean, the COVID-19 pandemic, which has swept the globe, you can see here that really this is the sort of live dashboard that I've taken for the WHO, really just showcasing, in a way, the number of cases worldwide as of Saturday, 29th of May. And globally, as of that date, there's been 169 million confirmed cases of COVID-19, and including 3.5 million deaths, according to the WHO statistics. And as of May 26, there's been really a total of 1.5 billion vaccine doses have been administered around the world. Well, what about the scenario in Australia? So thus far, really as of a few days ago, there's been 30,000, just over 30,000 cases of COVID-19. And currently there's 102 active cases. Of course, with the recent Melbourne outbreak, a lot of them are centered around there. 19 cases currently still hospitalized, and in total, there's been 910 deaths. Now, what is the current sort of vaccines that are available in Australia? So most of us would know that we have really two main vaccines. There's the Oxford University AstraZeneca vaccine, and that's from an adenoviral vector-derived sort of delivery system. Now, both the vaccines require 2 doses, and I guess with the initial clinical trials, after 1 dose, in terms of efficacy, the AstraZeneca has been reported about 70%. And as we know, it can be stored in really regular fridge temperature. The alternative vaccine is the Pfizer-BioNTech vaccine, which uses mRNA technology. Again, 2 doses, and in the clinical trials initially, after a single dose, the efficacy is around 90%. And as we might know, this requires a more stringent, I guess, storage conditions with a -17-degree fridge. However, more recently, in a real-world UK study looking at the efficacy of these 2 vaccines, there appears to be no actual difference in the efficacy after 2 sort of doses between AstraZeneca or Pfizer. And it seems to confer about 70% protection in terms against SARS-CoV-2 infection. So what's the current vaccination status in Australia? So as of a few days ago, we have 3.6 million doses of the COVID-19 vaccine administered, and an estimated around 2 million of these is the AstraZeneca vaccine. In terms of adverse events reported so far, that's just over 22,000, with 15,000 attributed to AstraZeneca. Given the majority of vaccines have been AstraZeneca vaccine, that's perhaps no surprise. And you can see there that just over 6,000 adverse events being reported for the Pfizer vaccine. Now, in terms of the nature of the adverse reactions, well, they're really quite common for what we expect for most vaccines. And you can see there that the top 5 most common reactions reported for both vaccines are listed there. And I'm sure many of us in the audience, myself included, have certainly experienced some of these complications. Now, besides the common adverse effects, of course, there was a bit of a signal really earlier in March this year. So really looking overseas to our UK colleagues, the British Society of Haematology had posted on their, in a way, their news bulletin board that they've discovered a rare syndrome of thrombosis that appears to be associated with unusual sites of thrombosis, really usually with thrombocytopenia that's occurring after coronavirus vaccination. And I guess on their bulletin board, they have recommended that, to really keep an eye out for this particular thrombotic syndrome. It appears to affect patients of all ages and genders. And at that particular moment, there was no idea in terms of what the risk factors are for developing this thrombosis. Subsequently, around mid-March, the regulatory bodies in the UK and European Union had acknowledged that the AstraZeneca COVID-19 vaccine may be associated with a rare thrombotic complication. And a few weeks following that particular statement, in the New England Journal of Medicine, there was 2 publications reporting really the initial sort of series reporting these thrombotic complications. With a German-Austrian case series, they described 11 patients, 9 of whom were women, and you can see the median age was 36, with the range 22 to 49. The thrombotic events occurred 5 to 16 days after vaccination, and all except 1 presented with at least 1 thrombotic event. Unfortunately, there was 1 who presented with a fatal intracranial hemorrhage without thrombosis. So 9 patients in that cohort had cerebral venous thrombosis, while 3 had splenic vein thrombosis. But of course, there was also evidence of, in a way, more typical sites of thrombosis with pulmonary emboli as well as DVTs. And quite concerningly in that series, you can see that the mortality rate was about 54%. In terms of laboratory features of these 11 cases, the finding was that there was significant thrombocytopenia. So the median platelet count in that German-Austrian series was around 20, and you can see that the range was between 9 to 107. And quite interestingly, in the patients who had complete coagulation profiles, 4 out of 6 of them had very low fibrinogen. And very interestingly, 5 of the 7 patients had D-dimers well and truly above the normal range. So the lowest level was 1.8 milligrams per liter. So to give you an idea, our normal range for D-dimers is usually 0.25, and the lowest D dimer was well and truly above our normal range. In the same New England Journal article, the Norwegians also described their case series of 5 patients. Again, a majority were women. 4 of the 5 had evidence of cerebral venous thrombosis, and again, presenting a few days after vaccination. The platelet counts range in, very similar to the German-Austrian case series, between 10 to 70. And again, this finding of a markedly elevated D dimer. So in 4 out of 5 patients, the D dimer was well and truly more than really what our normal, reported upper limit is, which is greater than 10 milligrams per liter. And the lowest number D dimer they had was 13 milligrams per liter. And again, the observation that some of these patients had low fibrinogen levels as well. In terms of mortality, which is similar to the German-Austrian series, around 60% of patients succumb to their thrombotic complications. All patients have received some form of heparin anticoagulation, and 4 out of 5 patients receive intravenous immunoglobulins. And you can see that the majority of patients have also received platelet transfusions as well. The week following that publication, the UK group published their series on the largest published, case series to date. And very importantly, and I'm sorry I skipped too early, for the first time, there was finally, a proposed pathophysiology, given that in this case series, we detected the majority of patients had presence of these pathological antibodies to platelet factor 4. So, what is platelet factor 4? So firstly, before we go on to that, we need to talk a little bit about the, definition, because you can see probably in the literature a number of different, names that we call this thrombotic syndrome. We have TTS, but we also have vaccine-induced thrombotic thrombocytopenia. And there's also vaccine-induced prothrombotic immune thrombocytopenia. But really, they're all describing the same sort of syndrome that's been published in these case series. The unifying feature appears to be in all these case series that the majority of patient cases have evidence of these pathological antibodies directed against platelet factor 4. And platelet factor 4 essentially is something that's released from activated platelets from within the platelet granules. And really what's quite fascinating is that it is very, very similar to another prothrombotic immune-mediated thrombocytopenia that we call heparin-induced thrombotic thrombocytopenic syndrome. And to, in a way, understand potentially the pathophysiology of VIT, we need to understand the pathophysiology of HIT, which I'll describe, by using this schematic. So platelet factor 4, which resides in platelets, release upon activation, it is a very positive charged cationic molecule, whereas heparin is a very negative charge anionic molecule. So typically, upon exposure to heparin, platelet factor 4 can really bind to the heparin molecules where they're unfractionated heparin or low molecular weight heparin. And with this, interaction in some susceptible patients, they develop an autoimmune response where pathological antibody develops where it's able to recognize, the heparin as platelet factor 4 complex. And with the development of this pathological antibody, in certain configurations, so it appears that you will need to have 2 of these pathological antibodies in close proximity to each other, attached to a corresponding platelet that can then induce spontaneous platelet activation. And it's by this platelet activation that is the reason why in these patients thrombosis can occur, and also causes the rapid drop in platelets, causing the thrombocytopenia. Now, of course, the intriguing thing in vaccine-induced thrombotic thrombocytopenia is that the patients have not been shown to be exposed to heparin. So the question that still remains is that, well, what is the anionic substance or the polyanion that the platelet factor 4 is binding to that's causing the body to produce an antibody against? And that is still the subject of much research at the moment. So let's glance back at the UK series and the sort of biggest series to date of 23 patients. And looking at this larger series, we're seeing now that there is a more, even distribution in terms of the gender. So 14 for women, The median age now is a lot more higher. So instead of around median age of 30 to 35, it's now 46. And you can see in terms of the range, there's, it's ranging from 21 to 77 years old. And in fact, you see there that 30% of patients are actually older than 50 years old, with the majority being younger. Again, what we see is slightly different is that the time to presentation occurs as late as 24 days after AstraZeneca vaccination. In terms of site of thrombosis, you can see that 59% of patients had cerebral venous thrombosis. But however, the second most common type of thrombosis, though, is the more typical DVTs or pulmonary emboli. And what's interesting is that, yes, there was evidence of splenic vein thrombosis in 9% of patients. But what's interesting is that 2 patients had evidence of ischemic strokes involving the middle cerebral artery territory. In terms of mortality, what was pleasing to see was that mortality was not quite as high as the initial report, with December 23 patients succumbing to their thrombotic events. Now, what was one of the key observations that was reported in this study is the fact that additional thrombosis events in these patients appear to be associated with patients who receive platelet transfusions or heparin-based therapy. And the theory is that by providing more platelets and therefore platelet factor 4 is sometimes feeding the immune, response that's pathological in those patients. And there's also a concern that by exposing patients to heparin, really much like the HIT scenario, by providing again more substrate to bind to platelet factor 4, that might be then in a way stimulating more immune production of antibodies and encouraging thrombosis. So from the latest, May 5th data from the UK regulatory bodies, you could see there the overseas incidence of VIT, which is approximately 1 in 92,000. And I guess before we go on, we have to, in a way, have some perspective for those statistics, because in Australia, 17,000 of patients would be diagnosed each year with some form of VTE. And a lifetime risk of VTE would be roughly 1 in 1,200. So I guess we have to keep that in mind. Certainly, that's something that I discuss with my patients when I counsel them regarding, relative risks. I do point out that one is far more likely to develop a spontaneous VTE throughout their lives than one from, vaccine. Now, going back again, to some of the things we learned from the initial case series is that really what's of critical importance, of course, is testing for the presence of these pathological anti-platelet factor 4 antibodies. However, this can only be done in selected reference labs here in Australia. And really, I'll leave to my colleague, Professor Vivien Chen, to talk a little bit about that later. What we learned from our overseas colleagues, and this is our local experience, that we need to use non-heparin anticoagulants and either parenteral anticoagulants which we use in hospital, of direct thrombin inhibitors like bivalirudin, or really a particular heparinoid product called danaparoid. However, we can also use oral direct, the oral anticoagulants as well. I think from the UK series and the ones before then, it appears to be important to avoid platelet transfusions if possible. And really from experience overseas, the use of intravenous immunoglobulin appears to be helpful potentially in reducing the platelet activation. And our UK colleagues certainly have recommended in very severe cases of vaccine-induced thrombosis to consider plasma exchange therapy in hospital. Now, on the 23rd of May, the ATAGI group, which is the Australian Technical Advisory Group on Immunisation, in collaboration with ARMS, have released a joint statement to address this rare complication. And really, together we had come up really what we consider the following patient groups that we believe there's currently no evidence that would show that they have any increased risk of developing this rare immune reaction to AstraZeneca vaccine. And we all agree that patients with a past history of VTE in typical sites, such as DVT or PE, do not have a contraindication to proceed. Patients with a thrombophilic disorder also does not appear to have increased risk of developing a vaccine-induced thrombosis. And this, of course, would also apply to patients with family histories of thrombosis where they might not have a detectable thrombophilic condition. we're pretty comfortable that patients already on anticoagulants can proceed with vaccination without any increased risk. And also, patients with previous history of arterial ischemic events, such as ischemic heart disease or cerebral venous accidents, cerebral vascular accidents, can also safely proceed with no apparent increased risk as far as the evidence suggests so far. We also think that patients with current or past history of thrombocytopenia can proceed with AstraZeneca vaccinations. In this statement, we also had listed the patients whom we believe should consider the Pfizer vaccine as an alternative. And given the experience overseas, as I described regarding the increased rates seen in patients younger than 50 years old, so anyone under 50, given the risk of vaccine-induced thrombosis, although low, we do think it's appropriate that they proceed to have the Pfizer vaccination. And for other patient groups, we had felt that patients with a past history of cerebral venous thrombosis or of heparin-induced thrombocytopenia should not receive the AstraZeneca vaccine and therefore should have the Pfizer one. And also patients with a previous history of idiopathic splenic vein thrombosis should also have the Pfizer vaccine. Another group of patients that we've felt should also receive Pfizer is the patients with antiphospholipid syndrome with a history of thrombosis. Finally, the last group of patients that we think really should consider Pfizer as the preferred vaccine is, of course, patients who have previous anaphylaxis to the first dose of AstraZeneca vaccine or to some ingredient within it. And also, of course, patients who developed vaccine-induced thrombosis with their first dose. But really, the third group, though, will be any patients who develop a serious adverse event, related to the first dose of AstraZeneca vaccine. And this can be defined, I guess, by either serious thrombosis in the venous or arterial systems. And with that, that's the conclusion of my part of the presentation. And I will hand over to our next speaker, Professor Vivien Chen. Thank you very much.
Thanks so much, Danny. And we will just change over that screen share for you now and carry on. And then we will move on to answering some of your questions after Vivien has presented her slides.
So thank you very much for the introduction, and thank you to Danny for setting the scene. So I'm going to spend a bit of time talking about the THANS guidance for diagnosis and management of vaccine-induced thrombocytopenic thrombosis, also known as TTS. And talk through some of our Australian data so that you can get a feel for what we're seeing here on the ground in Australia. If my slides will progress. So what is the scope of the problem here in Australia? The Australian incidence, according to the TGA data, is at the moment estimated at around about 1 in 88,000. Unlike those early case series that Danny presented, it really is affecting all age groups and genders. And in fact, within the Australian cohort, 66.6% of Australian cases are actually male. So don't think that it's only females that can be affected by TTS. Although well-controlled thrombosis does occur in this syndrome, the occasional rapidly progressive catastrophic thrombosis has been seen, which is why we want this syndrome to be picked up early and treated early. And the reason for this is that treatment is different for VIT or TTS compared with standard thrombosis. We want to, because it is this immune-mediated thrombotic syndrome that Danny has described, anticoagulation alone may not be enough. And for the severe thromboses, we really want people to immediately commence immune therapy, in particular an infusion of IVIG to compete that antibody off the platelets to prevent that platelet activation syndrome. We want patients to be started on non-heparin anticoagulation and to avoid platelet transfusion, even if the patient presents with a very low platelet count. And early diagnosis is the key to improved outcomes. And compared to those very early cases, our mortality here in Australia is less than 10%. And I think that with early diagnosis, we can keep it that way. So we've developed two sets of guidances for management of VIT here in Australia. The first one we developed was a guidance for specialist care, really directed at our haematology colleagues. This was formed by the THANS VIT Advisory Group, which is a group of Australian New Zealand experts in thromboembolic disorders and laboratory hemostasis, where we reviewed all the publications, pre-publications on VIT, the information from the regulatory authorities from around the world, and the available guidance from international societies. And we developed a guidance document that is available online through this link. And this is a living online guidance document. Every week we meet together, we review the published evidence, and we also look at the clinical and laboratory data of all confirmed Australasian VIT cases. And based upon that, we update our recommendations for you every week. The document at the end lists the hemostasis contacts within your state and territory, people who are happy to be contacted to discuss any concerns that you have about individual patients. And as Danny mentioned, THANS does meet with to inform ATAGI about our views on the science behind VIT, and you can watch the ATAGI site for ongoing updates. So in addition with this, led by Danny and Ai-Vee was the College of GPs representative on this, we developed a multidisciplinary guidance for recognition and initiation of management of VIT, which is available through the link below. And I'm going to go through this guidance with us for you tonight. So when should you suspect VIT? You should suspect VIT when patients present with symptoms suggestive of either thrombosis or thrombocytopenia within 4 to 30 days of AZ vaccination. This syndrome has not been seen with the mRNA vaccine such as Pfizer, and so it's really the AZ adenovirus vaccine that we're looking at. We have not seen a case yet before 4 days, and we think that's because you need to have that 4 days to make that antibody response. Now, if you have symptoms of thrombosis, then as a primary care physician, you need to initiate the appropriate investigations or recognize when the investigations need to be initiated, I guess. So thrombosis can occur at any site. Neurological symptoms of CVST can include headache, persistent headache. It doesn't need to be severe, but it is usually persistent. And the headache can be associated with neurological signs, visual changes, seizures, focal neurological deficits, and even symptoms of encephalopathy. So anything unusual with your headache, I think, needs to be investigated. The symptoms of splenic thrombosis may actually be quite subtle. And so patients presenting with a characteristic blood picture that I'm going to show on the next slide with abdominal pain should be sent for investigation for splenic thrombosis. Of course, DVT and PE symptoms I don't need to tell you about. Arterial thrombosis has also been seen. We've had one patient who's presented with renal infarction, other patients that have presented with stroke. And once again, early diagnosis is the key to improved outcomes. So how to investigate? Well, while the suspicion of VIT is being explored, there are a few key things to note. We need to avoid platelet transfusions because, as Danny's mentioned, platelet transfusions may add fuel to the fire, increasing the thrombotic complications. We are avoiding beginning heparin-based anticoagulation, and fortunately, we have a lot of excellent alternatives. And within primary care, that will usually be the DOACs. Apixaban or rivaroxaban commenced with the normal loading doses of rivaroxaban and apixaban. If you have symptoms suggestive of CVST or splenic thrombosis, I'd be calling my haematologist while getting the patient to the emergency department, because in these patients, we want to commence IVIG urgently and get them onto a parenteral anticoagulant. So the blood investigations for VIT, fall into two categories: the screening tests, which can be initiated in primary care practice, and the confirmatory tests, which will be done a little bit later. So I've taken this diagram from the multidisciplinary guidance for VIT diagnosis and management, which hopefully you will all have had a copy of, circulated from the College of General Practice. So going through the algorithm, if your patient presents with acute onset of symptoms with signs of thrombosis or thrombocytopenia, having received the AZ vaccine within the last 28 days, then you don't give a heparin anticoagulant, and you urgently obtain a full blood count, a APTT, PT, and fibrinogen, but importantly, a D-dimer test within 4 hours. And what you're looking for is, does that patient have a platelet count less than 150 and a D-dimer that is at least 5 times the upper limit of normal of your particular test? And so different labs will have a different cutoff for upper limit of normal, and so you need to look at that particular lab's upper limit of normal cutoff. And this D-dimer test is really key. This is a very elevated D-dimer. It's not, often when we see a DVTPE, even a large one, we're seeing D-dimers of 0.8, even 1. This is a really abnormally high D-dimer. And in addition to this, some patients will have a low fibrinogen. Now, if you don't meet those criteria, if you don't have the platelet count less than 150 and a raised D-dimer, then we would consider VIT unlikely, and you need to consider alternative diagnoses for the thrombosis, including vaccine-unrelated VTE, and you need to investigate and manage accordingly. There is one caveat, and I'll show you some data to explain that. If there's a high index of suspicion, or if there are persistent symptoms, then we're going to encourage you to do another full blood count. And if there is a downward trajectory of the platelet count, the patient may still have VIT and need to go down the alternative pathway. So if you have a high D-dimer, that very high D-dimer, greater than 5 times the upper limit of normal, with a normal platelet count and thrombosis, I'd suggest repeating the platelet count within the next 1 to 3 days. And if that platelet count is on a downward trajectory, then refer the patient into the emergency department, because the tempo of disease can be catastrophic within hours. And we strongly advise careful clinical review of persistent symptoms with repeat screening blood tests in patients with a high index of suspicion. So what happens if the platelets are less than 150 and the D-dimer is greater than 5 times the upper limit of normal? If the answer is yes, then you're going to, then we'd suggest that you refer the patient to the emergency department or organize urgent imaging according to the symptom site. If you've got headache with seizure, then you're going to be doing a CT venogram. If you've got shortness of breath, of course, a CTPA. But very importantly, at this point, it's important to collect and send samples for VIT testing. Within the multidisciplinary link, we have a QR code that links to the VIT testing form, and the VIT testing form, I'll show you a little bit later, includes spaces for you to put the patient information, which is key for us to determine the urgency of the testing. And in fact, the testing will not be done if we don't have the clinical information, because we don't have the resources to test the patients that are not likely to have VIT. After your imaging, if the thrombosis is confirmed, then you go down to this red box here. This is probable VIT. You're not going to give platelet transfusions. You're going to send the patient, you're going to consult hematology and send the patient into the emergency department. And start their non-heparin therapeutic anticoagulation after you've taken the blood samples for VIT testing. And these patients, if they have severe thrombosis, will require urgent infusions of intravenous immunoglobulin, 1 gram to 2 grams per kilogram in 2 divisions. Also on the multidisciplinary form link, you'll have a QR code which links you to the full SANS advisory statement, which is updated weekly if you want to get more detail on specialist care for these patients. If the patient has low platelets and a high D-dimer but no thrombosis, then VIT is still possible. And I'd be referring this patient to your local hematologist. Once again, we want you to collect and send the samples for VIT testing, and your hematologist may consider non-heparin-based prophylactic anticoagulation in these patients, as they may progress to thrombosis later on. So VIT confirmatory testing is done in 2 stages. We do an immunoassay looking for that antibody that Danny mentioned, and this is an ELISA test for the PF4 polyanion antibody, which we're now calling the VIT ELISA. The other tests that we have for HIT testing do not reliably pick up the VIT antibody and are not appropriate for this particular condition. In addition to this, we have centralized laboratory assays. We're doing functional VIT assays. The ability for the patient's plasma or serum to activate platelets in the test tube is pathological and requisite for confirming the diagnosis of VIT. You won't get those tests back straight away. They may take a week to 2 weeks, and the patient should be treated according to clinical criteria in the meantime. I have mentioned taking off these tests. To be honest, we're getting the most appropriate samples when the confirmatory VIT testing is sent through the hospital-based laboratories rather than the private laboratories, and we can talk a little bit more about that later. So very briefly now, I'm just going to go through some case vignettes which explain how to how one uses that algorithm that I've just shown you. So case 1 was a 44-year-old man, previously well. He presented to a Metropolitan Hospital day 8 post-AstraZeneca vaccine with abdominal pain. At presentation, his platelet count was 70, his D-dimer was off the scale at greater than 20 milligrams per litre. His fibrinogen was actually normal. Within the time he was in the emergency department, he actually developed petechiae, and a repeat platelet count was 17 times 10 to the 9 per litre. Blood was taken for his VIT testing. He had an urgent ELISA, which was strongly positive, commenced IVIG even before he went to the CT scanner. The CT scanner, on CT scan, he was confirmed to have extensive splenic vein thrombosis, and he was commenced on fondaparinux, a non-heparin-based parental anticoagulant, changed to bivalirudin, which has a shorter half-life when he needed to go for surgery. And the specific VIT confirmatory tests came back as positive. He was a confirmed VIT, and he stabilized after 2 weeks and was discharged from hospital. Case 2 was a 60-year-old woman who had a background of quiescent SLE, who's not on any current autoimmune therapy, and she presented to a Metropolitan Hospital with a swollen, actually a regional hospital with a swollen leg and a blue toe, day 4 post-AstraZeneca vaccine. And at the time of her initial presentation, her platelet count was normal. It was 154 times 10 to the 9 per litre, but you can see that that D-dimer was very elevated, 22 times the upper limit of normal. Fibrinogen at that time was normal. Very appropriately, a compression ultrasound was ordered. There was no DVT at the home at that time. She was discharged home from the emergency department, and it's unclear exactly how stringent the advice was with regards retesting the platelet count and representing. Over the next 5 days, she had some non-specific symptoms, and she didn't seek help from her primary care physician. And on day 5 post-discharge, she came back to the emergency department with headache. Platelet count at this time was 24 times 10 to the 9 per litre. D-dimer now off the scale, greater than 20. Fibrinogen low, 0.5 grams per litre. And her CT venogram showed extensive CVST with venous infarction and secondary hemorrhage. Her VIT bloods were taken, IVIG commenced, IV gatroban, another non-heparin anticoagulant, and cryoprecipitate because of that low fibrinogen and the hemorrhage. Her specific VIT confirmatory tests were once again ELISA positive, functional assay positive, and this woman needed to proceed to a thrombectomy on day 3. By day 5, her platelet count had recovered, and she was discharged home day 10. Case 3 is a less catastrophic case. A 52-year-old man who was otherwise well presented to the emergency department with a painful swollen leg, was found to have a popliteal vein DVT on imaging, no other symptoms of thrombosis in other sites. And that's key because a lot of our patients with, who are presenting with DVT, we're finding also have PE and CVST. And not a lot, but some of them also have thrombosis in other sites. So this gentleman had a platelet count of 93 times 10 to the 9 per liter. His D-dimer was up, but not catastrophically. 14 times the upper limit of normal. Fibrinogen was normal. Once again, the confirmatory bloods were sent, and this patient was commenced on rivaroxaban at full loading dose, 15 milligrams twice a day orally. By day 2, his platelet count had recovered. It was elected by his haematologist not to give IVIG. His symptoms resolved by day 3, and he's progressed with no complications. And his VIT confirmatory tests once again came back as positive, but low positive. Case 4 was a 60-year-old woman who was otherwise well, presented day 3 post AZ vaccine, and already that gives us an alarm bell that this woman is presenting before that time period that we've talked about, day 4 to 30. She noticed petechia in her lower limbs and wet purpura in her mouth, no symptoms of thrombosis, so presented with a bleeding phenotype rather than a thrombotic phenotype. Her platelet count was 3 times 10 to the 9 per liter. Her D-dimer was 0.3, which is within normal range. Fibrinogen was normal. And this woman was treated as vaccine-induced immune thrombocytopenia, treated with IVIG and dexamethasone. Her specific VIT confirmatory test came back with a negative ELISA, and the functional assay was not run, and she does not have VIT, she has ITP. So I'm just going to very briefly show you some of the laboratory data on the Australian VIT cases, particularly the platelet count and the D-dimer presentation. So you can see here that of the cases where we're, according to the SANS criteria, we have called confirmed VIT, the majority have a low platelet count. Some of them have a very low platelet count at 10 times 10 to the 9 per liter. But there is a significant minority where their initial presentation platelet count is normal. And that's why I've emphasized that if your index of suspicion is high, repeat that platelet count, see if there is a downward trajectory, because the pathophysiology is that this antibody consumed leads to platelet consumption. And so it's that downward trajectory that is important, rather than a single time point. These are the D-dimers of the patients at presentation. All of them have been greater than 5 times the upper limit of normal, and a significant number really higher than the upper limit of normal, higher than our undiluted tests go out to. I did want to point out the age. Since Australia, since the federal government has recommended against individuals under the age of 50 receiving the AstraZeneca vaccine, the age of the patients presenting with vaccine-induced thrombosis, thrombocytopenia is in general higher than 50. This so it's not that people greater than age 50 can't get TTS. The incidence is less in patients that are over the age of 50, and perhaps we're seeing a milder phenotype than in the under 50 age group. But of course, our median age is closer to 70 because of the cohort that we're vaccinating with the AZ vaccine. And the sites, you'll see that this doesn't add up to 100, and that's because there are individuals that have thrombosis in more than one site. The majority of the Australian patients are actually presenting with thrombosis in more standard sites. They're presenting with DVTs and pulmonary emboli. A significant proportion do have cerebral venous sinus thrombosis, splenic thrombosis. A minority at the moment have arterial thrombosis. And I just point out that the data that I'm showing you here meet the criteria for the Thrombosis Hemostasis Society of Australia and New Zealand for VIT, they may not all have been adjudicated by the TGA yet. So the next case just is to illustrate the importance of that information sheet that is given out at the time of vaccination. So a 40-year-old woman who's well informed decided that she was going to get the AZ vaccine, traveled out of area, and so she didn't have access to her usual primary care physician. Day 10, she developed worsening headache and did not seek medical attention, and she had a persistent headache for the next 6 days. She was brought in by ambulance with seizure. Platelet count was 34, D-dimer greater than 20, fibrinogen 0.8. Radiology confirmed that she had CVST with secondary hemorrhage requiring craniotomy and once again thrombectomy. So I understand that there is an information sheet that is given out at the time of vaccination. I might ask Ai-Vee if she can comment on that, and also issues that have just been settled with regards insurance. Ai-Vee?
Yes, thanks, Vivien. From a vaccination site's perspective, I think it's really important to be counselling our patients. And even prior to vaccination, it's important to do so, but definitely at the time of vaccination, that we're giving them information about the fact that TTS does exist, and bring home the message that it is incredibly rare, but it's also really important that they watch out for possible symptoms of VIT, so that if they are developing symptoms, they know to get medical attention as soon as possible. Part of that might involve giving them the Department of Health after your AstraZeneca vaccination information sheet, which is very easily found on the Department of Health web page with all the COVID resources there. But you know, from a counselling perspective, I might typically tell my patients about the fact that if they've got a headache that's persistent post vaccination, specifically days 4 to 30, it's not the usual headaches and not settling down easily with Panadol and Nurofen. Or if they've got abdominal pain that's there, again, days 4 to 30, or anything else that's unusual for them, including a rash, then they really need to come back to see us. And I give them very specific advice about saying, look, ring us up if it's during normal working hours, you know, what to do if it's after work, normal business hours, and also give them the opportunity to access care in the ED if they can't access GP care either during or after our period. Charlotte, what do you tend to do?
Yeah, I think that as you said, the important thing is to make sure people are not only fully informed prior to getting the vaccine, but that they actually do get the information sheet or know where to access it for afterwards. I think the learning lesson from the case for the 40-year-old is the 6-day delay in seeking any attention, despite the fact that she had a persistent headache for that amount of time. And so we do know that if you present sooner, then you're more likely to have a better treatment and prognosis pathway. The other issue to know is that the college has been advocating strongly for a no fault insurance for patients undergoing vaccinations in the Australian footprint. And so good news is that has been agreed to, and my understanding is that it is going through Parliament at the moment and will be publicly announced. But that will basically protect both patients in terms of having an ability to seek some form of financial support for whatever morbidity is suffered from the vaccine effects, but also for us as GPs and our vaccination teams to be protected from needing to be sued in order for patients to get the compensation for any adverse outcomes. So I think that's a great outcome, even though the fact that we're having to have this scenario on us is not a good reason for that, but I think that's a good long-term vaccination insurance for Australians. Do you want to keep going, Vivien? Is there more information?
Yeah, I've just got 2 extra slides. It's just reminding everybody that there is information to hand out to your patients, exactly as Ai-Vee and Charlotte have mentioned. So this is the New South Wales Health sheet that was put out on the 23rd of May. I'm sure that every state and territory has their own. This came out after the joint statement from Itaji and Fans on TTS and the use of COVID-19 vaccine, where I found it very useful to give my patients who have, particularly in this group, who are concerned about getting the AZ vaccine, because it clearly states that the following groups can continue to receive the AstraZeneca vaccine. And if your patient falls into that group, hopefully having something to take away with them is helpful. The other thing that is mentioned within that Fans-Itaji statement is that people who have had their first dose of AZ without serious adverse events can receive the second dose. The data that came out after the first, I think 7.8 million second doses were given in the UK was that there were no confirmed TTS cases after second dose in the UK. There were 8 cases of serious thrombosis, none of which had the antibody detected at the time when that statement was made. And so even if that is, even if all 8 of them ended up being TTS, that's still a 1 in a million, which is a nicer number than 1 in 88,000. So I guess our aim is to make it a manageable complication rather than a vaccine limiting one. We believe that in the majority of cases, it is a treatable condition, particularly if we have awareness of the diagnostic and treatment pathways, if we recognize the pattern of the screening tests, and I'm happy to accept questions.
Thanks so much for that, Vivien and Danny. I might quickly, Danny, I see you've been looking at some of the questions and answers. Would you like to address a few of the ones that you can easily sort of quickly cover in a group way, and then we'll try and make sure we cover as much as we can?
Sure. So, Charlotte, do you want to go through the ones that I might have already answered by typing, or the ones that are still open? Because I'm assuming
probably still open, or that you don't think have been addressed at all yet.
Sure. So I might have a crack at some of the questions, and Vivien, I'll handball some over to you when it gets too hard. So I think the one that has the most thumbs up is the new antiphospholipid syndrome with thrombosis being a contraindication. What should we do with the patients with a history of DVT who haven't been screened yet? Should we screen first? Should we screen, or should we screen all those who have a history of DVT? So yeah, the short answer, yeah, I agree with your shaking of head. It is probably not in those patients. I mean, look, they would have, you would expect the patients with APLS are highly prothrombotic, and they really would have presented, you would think, without the vaccine, they would have had spontaneous thrombosis really out of the blue from the onset. So, unless there's a clear, obstetric history of, recurrent miscarriages, more than 3, or they've got a prolonged APTT, so really clear, signs or signs that they've got APLS.
So don't go looking for trouble.
Don't go looking for trouble. Correct.
Can I just mention something there, Danny? Just that the people that we're worried about are the people that have this really catastrophic immune-mediated thrombosis that manage to clot despite anticoagulation. They're the people that we're worried about. We're not worried about whether or not you might have an antiphospholipid syndrome antibody that is lurking in the background with a well and easy to manage clot in the past. The people we're trying to protect are those that that clot through everything, and you'd know if that you had one of those patients. They're the ones that make Danny and I lose sleep at night.
Yep, and they'll be seeing us quite regularly.
They'll be seeing us.
Can I? And can I also make note that we are going to see some patients who get clots that are not in this syndrome and are not related to this, because there's higher incidence of clots just happening anyway that are just going to be incidental and or happening because of other life things. And it's important not to get those tied into the way in which we respond to AstraZeneca.
Yeah. Absolutely.
I just also note there's a couple of people quite concerned about the incidence of this with Pfizer, because you said specifically it wasn't related to Pfizer, and then there's people saying, well, but I've seen some reports that it is. Can we just clarify around Pfizer? There is no incidence of VIT with Pfizer. Some of the other, Pfizer does have adverse reactions associated with it, but it doesn't have VIT.
Correct. And so immune thrombocytopenia is definitely seen with both Pfizer and AZ, but just this very specific TTS VIT syndrome does not appear to be associated with Pfizer. It does seem to be associated with the adenovirus vaccines.
And so
can I also, sorry, I'll just very quickly also clarify that the age range for the choice for AstraZeneca in Australia was done on a risk basis. It was not done on the fact that only people in the younger age group get it. It's more about the number of cases and the catastrophic events that were associated. The younger you are, the higher that incidence. Hence, for Australia, with no community case, 50 was seen as being the right age group.
Absolutely, Charlotte. That's beautifully put.
I was just going to go back to the Pfizer vaccine. You mentioned that immune thrombocytopenia is certainly seen following the Pfizer vaccine as a possible serious adverse reaction. Have thrombotic episodes been seen following the Pfizer vaccination as well, independent of thrombocytopenia?
Yes, but presumed coincidentally, not associated with the antibody. And so that's a very key point that we try to emphasize in our advisory statement, that actually the majority of the thromboses seen in that 4 to 30 days after AstraZeneca vaccine or after Pfizer vaccine are coincidental. They're not antibody driven, and they can be treated using your standard anticoagulation pathways.
I think I always highlight to patients again that they're 800 times more likely to clot randomly out of the blue in their lifetimes than from the vaccine. We, as a thrombotic hemostasis specialist, every week we'll be seeing plenty of patients with random ETE. So that's what we try to describe to patients, that what we're seeing with these sort of non-bit related is just a background that we normally would see anyway. It was never very sexy, unfortunately, until TTS hit, but VTE now is still in the spotlight. Yeah.
My last CBS. Sorry.
No, I'm just sort of seeing what the time is, so we're going to be rapidly running out of time. But I just want to note that the AstraZeneca is a 12-week apart vaccine. You can administer it up to 4 weeks apart if someone needs to be rapidly have their vaccine boosted, but you do not get as good a response. The longer you wait, the better. So that's why our recommendation is 12 weeks, but people can have it earlier if they clinically need it because you're wanting a higher protection. Ai-Vee, are there some other questions you see that we do?
I thought we might just group a few of these questions together, but there are a few questions around blood tests before AZ vaccination. Is it worthwhile? Do PF4 antibodies possibly exist before vaccination, or is it thought to be induced post-vaccination?
That's a really good question. So the short answer is no. We do not recommend you do screening PF4 antibodies before vaccination. The pathological PF4 antibodies, they're going to be induced after vaccine, and the risk is that we will find a false positive before the vaccine that will cause problems.
And I just want to add to that, what's really interesting is that, there appears to be in some patients a very low incidence, very low titer background of PF4 antibodies. So in one particular study, up to about 7% of healthy blood donors had evidence of very low titer anti-PF4 that didn't activate platelets. So they're not the pathological ones we're talking about. When there was a study recently also looking at, whether, I guess, patients with either Pfizer or AstraZeneca would have developed antibodies afterwards. They showed that the rates of PF4 antibody detection, again, not the pathological, strong antibody that could activate platelets, was about 5.6% after Pfizer and about 8% after AstraZeneca. So, but really, I mean, they've acknowledged that, when you look at those patients, I mean, 60% of them were actually already pre-existing when they had, access to pre-vaccine samples. So, it's a fascinating thing that, you can have, because there's physiological background of a non-pathological anti-PF4 antibody, but doesn't necessarily increase your risk of actually developing pathological VIT, just to make things more complicated. Yeah.
Which is why we have those 2 stages of testings. We look for the we do an immunoassay looking for the antibody, but then we see whether or not that those antibodies are actually functional, whether they activate platelets in vitro in an antibody-dependent manner.
Thank you for that, Danny and Vivien. Can I slip in one final question from the chat?
Let's go for one last question.
Which is this recommendation for urgent blood tests. And there's been a couple of comments, rural, semi-rural areas certainly, or, some community settings wouldn't permit that urgent 4-hour turnaround. First thing, what do we do with the patients in the interim, even if we can access them? Are they urgent blood tests within the 4-hour period? And then secondly, if we can't access it, what's plan B? Should we be contacting somebody?
So the first thing to say is the screening blood tests that we're talking about, that full blood count, the D-dimer and the fibrinogen. The confirmatory tests, you just store the blood, you store the plasma away in your testing lab, and then that can get sent to us in a timely fashion. The short answer is, if the patient has a thrombosis and they're not bleeding, then you would treat them as if they have a thrombosis. And in most outpatient settings, if that would be treating them with a DOAC. If they have symptoms, just as you would with anybody else who presented with with symptoms of a thrombosis, whilst you're waiting for your confirmatory investigations, you would treat that thrombosis. Just avoid the heparins until you have those blood tests back. Danny?
Yeah, it is a difficult scenario, and I really do feel for our rural GPs. I mean, when you're stuck, and really, I think more than happy to, I think in the list of the thrombosis, I guess doctors, we're more than happy to be contacted for any advice, I think, in that scenario, because I think it is very specific depending on the clinical presentation. We acknowledge, I think there's going to be significant challenges in getting a rapid turnaround, and really, I think please call one of us, and we're happy to offer any suggestions that we can. Because really, I don't think this, unless we get results, is very, very difficult, and we acknowledge that. And but we're here to help, essentially.
And the other thing is, of course, if the patient is very unwell, then they just need to get to an emergency service, I guess, in the way that they would always get to an emergency service in any other situation.
Absolutely. And that does bring us to 8:04. We do apologize for going a few minutes over time. We've just received so many great questions here. I just want to really thank our presenters and facilitators for joining us tonight, Danny, Vivien, Charlotte, and Ai-Vee, and also to everybody that joined us online. We know we didn't get to all the questions. It was never going to be possible, but thanks for sticking with us, and enjoy the rest of your evening, everybody.